Okay, folks, so Chapter 7 of the ACE 6th edition Certified Personal Trainer textbook, and Chapter 7 is going to start Section 3, which is the section, there's 5 chapters here on assessments, programming, and progressions. Up till now, the first 6 chapters, basically some intro and some important information that leads us really into what we're going to be talking about here for the next 5 chapters on actually measuring variables that are important to develop a baseline of information that you will be able to retest, reassess as time goes on with your client. It's sort of a paradigm that you have to get into when you're dealing with a professional way of dealing with clients, which is you've got to have actual data to start this process off with. Otherwise, it's going to be a challenge if an individual has cardiovascular issues, musculoskeletal issues, and you don't know about these and you start them training. So you got to have this way of thinking that always has you trying to collect data, respond to the training with new reassessments, and then continue this process over the lifetime of the client trainer relationship. So again, it's a paradigm that you got to be thinking about. It's very important from the perspective of test taking as well. Assessments, programming, and progressions. There's a lot of information that you need to know from a testing perspective as well. So again, you got to think, collect data. You've got to get objective data. Now, there's always subjective data, but we're really talking about here objective data. Blood pressure, heart rate, all of the anthropometric measurements like body fat. These are the things that you need to know how to do. And then just keep in mind, and ACE will tell you this right from the get-go, it's not always a good idea to do assessments, initial assessments. Why? Because what we know, and we've known this for a long time, not everybody's motivated by getting their blood pressure taken. In particular, individuals that are overweight, they don't want you taking waist circumference measurements. And sometimes it can be a challenge to even do body fat measurements, especially with a skin fold caliper where you can't even grab the skin. You got to think about this. For some new clients, this can actually be a barrier. And so in order to ensure that you don't make it even more challenging for people to start their exercise programs, sometimes you're not even going to do certain assessments. However, for the knowledge base that you have to have, right, for the average client that you will be able to do this on, you need to know basically all of the basic assessments that you can do with an individual, and then how to do them. And so in Chapter 7, we're going to start off with what are known as resting assessments. And so resting assessments and anthropometric measurements. So again, Chapter 7, let's go ahead and get started. The first thing to keep in mind are what is known as sequencing the assessments. And by the way, forgot to tell you, remember to have your paper and writing implement so that you can take notes as you're going through this chapter. I sometimes get ahead of myself and forget. Each time you do this, make sure that you're prepped and ready to take your notes with the reading, right? Reading, rewriting it on a sheet of paper over and over, and then again saying it out loud. So right off the bat, it's a good idea to kind of get your brain now into this idea of sequencing the type of measurements you're going to do, right? You would do resting first. You're not going to do a cardio assessment and then do blood pressure, right? Some of this is just basically intuitive. And again, ACE actually tells you right at the very beginning of the chapter, not all these assessments are going to be useful, and not all of them are going to be ones that you're going to do with folks because they can be demotivating. It's as they say, the savvy personal trainer that knows how much to do, when to do them, and how to navigate through this initial process. Remember, you're trying to develop rapport with your client at this point. they've purchased your training program or whatever the case was, and now this initial engagement and relationship development can now lead to these assessments. And so this is the idea, is that if you're going to, let's say you have the perfect scenario and you're going to do all the assessments with your client, they're going to generally include on page 220 all of these resting vital signs. So we talk about resting vital signs. That would be heart rate, blood pressure, height, and weight. Static posture movement assessments. Now that's going to be in chapter 10. Remember, this a lot of what we're talking about here will be, they'll go in depth a little bit more in the particular subsequent chapter. So chapter 10 has flexibility testing, balance and core function. Cardiorespiratory fitness testing is going to be in the next chapter, chapter 8. Body comp and anthropometry is going to be in this particular chapter, but these are the important assessments that you're going to do. Muscular fitness, endurance, and strength, again, chapter 10, really important chapter. Skill related parameters as well, agility, coordination, that's all going to be in chapter 10. However, from chapter 7, I would write those down and make sure you know that those are, again, not every one of them you're going to do. For the most part, you're going to do probably 4 or 5 for the average client. But if you have an athlete, of course, you're going to be doing skill related parameters. So table 7.1 gives you a sample assessment sequence. Again, this is just a sample, and you just got to be careful that you don't, go memorize this by heart without realizing that this is a situation with an average client where you can literally meet with them the first session, and do the pre-participation health screen. Remember, back in one of the previous chapters, the health screening, right? That would be the first time you meet them. Again, memorize these bullet points. Your first, even during that session, when you're done with the pre-participation screening, you can move right into these assessments that we're going to be going over here in chapter 7. Now, you could wait for the second session. That's what this is saying. Again, don't be so dogmatic about what they're telling you here. They're giving you a sample, and that's what table 1 is going to give you an idea about. In the real world, normally the recommendation is we get all this stuff taken care of first round, first time we meet, knock it all out. And you might even do that before their first workout in some cases. And then every 30 days we do reassessments. That's kind of the real world, depending on the business model that you're going to follow. But ACE is going to say, look, there's a wide range of ways to do this and time sequencing. And so just keep that in mind as you look through table 7.1. Of course, in table, not table, but page 222, remember what I said. Once you hit these bullet points, stop, read them, be a little bit more engaged with the bullet points, because they're collapsing information and coalescing it for you. So it's not a bad idea to write it down, or to at least summarize what they're saying. So, for instance, this is giving you information from, again, the American College of Sports Medicine, which ACE tends to use quite a bit of, because they've got the research backing behind it. Distribution of instructions. I'm just going to read this for you, this first bullet point. Distribution of instructions in advance of assessments that clearly outline the client's responsibilities, what they should wear, eat, and drink, abstaining from certain products such as stimulants. So these are going to be sort of the assessment guidelines, for instance, that you would talk to. Now, what I would do is I would then take that, either write the entire bullet point, or more than likely, I'm going to summarize that. And I would just say, for that bullet point, I would write something like instructions for assessments. And that would be it. That'll keep my memory. What do I need to know about explaining this to my client, and what I would say to them? And that's how I would write. I would summarize it, because it's, it's a full paragraph almost. The second one also, Obtain and assigned informed consent from the client. What I'm trying to help you to do right now is to understand how, when I'm studying material, there's a strategy. I look at the bullet point. If I can summarize the bullet point, I'm going to summarize it. And that's what's going to help me. So now at the bottom of page 222, cardiovascular assessments at rest. Now they say cardiovascular assessments. Really what we're talking about are these anthropometric measurements that are inclusive to resting heart rate, for instance, and blood pressure. So cardiovascular assessments, heart rate, how do you take heart rate? There's any number of ways you can do it. Excuse me. You can do the wrist, right? The radial pulse measure, which you probably learned when you were in second grade, or at least you've seen it. So you can take an individual's pulse. Normally we use 2 fingers, left arm, and then the left arm, because this is where, since the heart is pumping directly to the left side of the body. Now, again, the aorta, the ascending aorta bends and goes to the left side of the body, not the right. So the left side, but there are branches off, obviously. But because of that, we tend to get a better, more substantial assessment from the left versus the right. Now, you could take it on the right. Don't get me wrong. It's not like you don't have a pulse. You do have a pulse on your right. Both arms, it's just you'll feel a stronger one here on the left. So we take it right where the wrist bends, right? And we simply find the bony protrusion right at the top here, right? Thumb side. And we simply take our fingers and we come down just into the groove. This little groove right here is basically where the radial artery from the radial artery now moves in towards the hand. You should be able to feel the pulse there. Normally, you're just going to count. It's up to you, by the way. Count for 6 seconds. How many did you get? Multiply by 10. That gives you a minute, right? Or you can count for 10 seconds. Only got 12, 13, 10 seconds is up. I got 12. Multiply by 6, right? And that gives you 72 beats per minute, however you want to do it. If you're having a problem here doing this, then you could, of course, do the carotid artery. And again, the idea is you find the jaw bone right there. What I do is I take my middle finger right here and put my index next to it, and then I simply drop down. And it drops down into this groove right underneath your jawbone, and you'll feel the carotid pulse right there. Try not to do this because that will occlude, or could occlude it. You won't feel it. Just up straight, and I just turn off to just an offset to the side, just like that. And you should be able to feel it. Again, count for 6 seconds or 10, multiply it by the proper number to get you to a minute. And that's your heart rate. Now, I will say this, the other way to do it is to simply use a blood pressure cuff. And so you can just use one of the automated blood pressure cuffs. That's what I would recommend. It's one way to do it. And that cuff that you put on a client's wrist will take you up to this point. It'll give you blood pressure and it will give you pulse as well. That's the easiest way to do it. So there, again, there are things that you could read on page 224 that's going to help you. Memorization of some of these classifications and categorizations is a really, really good idea. So bradycardia and tachycardia, those are at heart rates of, above 100 beats per minute, below 60 beats per minute. Of course, keep in mind that if your 25-year-old triathlon competitive triathlete client has a heart rate of 52 beats per minute, that's probably good. There's nothing wrong with that. If my 65-year-old client who hasn't worked out ever or for years has something like that. I might, obviously I'm going to have to now look into this. Is it due to medication? That might be it. So again, as you move through page 224, just keep in mind that each of these key notes that they're giving you on resting heart rate can be indicative of issues or problems or not. Now remember, you're getting an assessment. This is literally based on 66 beats per minute, 55 beats per minute, 56 beats per minute. Now what you do with that information is now you're able to kind of get an idea of where are the problems. Well, you already did your pre-assessment screening. You already did your pre-participation screening. You already did a PAR-Q. You already did those things. So you already knew. Now that you get into this assessment part of it, obviously you already know that because they're taking an ACE inhibitor or a beta blocker or some other medication, this is going to be, right? If you remember back in chapter, I think it was chapter 5, there was that table that told you these medications do this to resting heart rate, to training heart rate. You just go back to that, and that's what this is basically helping you out. So the idea then is that as you get through this page, you've got heart rate down. Generally, we're looking, just so you know, we're looking for resting heart rate to be an indicator of whether or not an individual's training program is effective, meaning cardiovascular training. It should do what? It should lower resting heart rate. It should lower recovery heart rate after exercise. These are the things that you got to keep in mind. That's kind of real world stuff. But they also want you to understand that there's a lot of issues that can change or modify resting heart rate. Blood pressure, and of course we've talked about blood pressure. Remember, blood pressure is simply a measure of the amount of force that the liquid inside the tube is exerting out. That's all it is. The liquid is blood, and the tubes are your arteries. So blood pressure is basically saying that because arteries are being stretched all the time, arteries are always being stretched, whether the heart has pumped or it hasn't pumped. Okay. The fact that there is fluid inside the tube, there is an innate pressure that is exerted. Now, that pressure can go up if I push more fluid into it. And then if that fluid volume backs down, it goes back to whatever that initial resting pressure was, so to speak. Well, there is your systolic and your diastolic. The systolic blood pressure is when the heart or the left ventricle pumps blood on that initial stroke, and it pumps out a volume of blood, and it forces the arteries to expand to accommodate that increased volume. That's a pressure. That's a higher pressure than when the heart relaxes and the artery squeezes back down. Now, when it goes back down to that resting state, what is the innate pressure of the fluid in the artery? Well, that is your diastolic. Systolic, boom, blood goes through, artery expands. There's a pressure associated with that, 120 millimeters of mercury of pressure, 150, whatever the number is. And then the heart contracts, blood goes into the arterial system, pushes through, expands the arteries, and then the left ventricle relaxes, and blood from the left atrium flows back in before the next stroke or next contraction. When that relaxation occurs, the artery goes back down, and now the blood flow, that laminar blood flow, that normal flow of blood, is at a much lower or innate intact pressure. That is your diastolic. It's a lower pressure, obviously, because it's just the pressure of the fluid in the artery. I hope that makes sense in that explanation. So because arteries can expand and contract, remember, they're muscles as well. They have muscular components to it. So blood pressure is measured relatively easy. It depends on the mode that you want to use. Again, the recommendation is for ease of use and relative accuracy, the cuffs that we use on our hand. Look, if you have a stethoscope and you're good at it, and you want to do the cuff on the arm and listen to it, that's great as well. They have automatic ones where the cuff goes on and all you have to do is you can either listen to it, or they have automatics that will actually give you the reading itself, not on the wrist, but literally on the brachial artery. It tends to be a little bit more accurate, but again, as long as you're using the same piece of equipment, same environmental conditions, your accuracy will be consistent, or I should say your level of inaccuracy should be consistent over the actual times that you're taking it. So again, blood pressure is important. The categories of blood pressure, please make sure you know that blood pressure guidelines and recommendations, they have changed, and they just recently changed, even from the 5th edition to now this 6th edition. And so it's really important to remember that that as you're going through this edition now, through this book, we no longer use the term pre-hypertension. So if you see that in materials, or you've heard it, or people tell you this, it's no longer used. We use the word elevated, and it's changed now because the systolic and the diastolic blood pressure readings, the cutoff numbers are pretty much the same. However, when you look at the category now, the normal is still the same, below 120 and below 80. So systolic below 120. So technically, if your blood pressure is 120 over 80, you are in an elevated status. Isn't that crazy? I grew up 120 over 80 was perfect. In fact, 120, between 120 and 129, not that big of a deal, as long as my diastolic was at 80. So these are the things that over the years, decades even, these things have changed because clinicians have gotten more research, more data. They look at longevity, they look at mortality, and they look at these things over the course of time, and more data that gets collected. The American College of Cardiology, for instance, American Heart Association, as they always continue to do research, they basically go, well, wait a minute, we're finding that it really doesn't matter that blood pressure was this or this, but boy, when it was this, then there was a higher mortality, also depending on age. So without getting into that too much, you do need to know Table 7.2 categories of blood pressure in adults. Remember, the key here are those words and or. So it doesn't matter what relation your systolic and your diastolic have. If you've got a, quote, good systolic blood pressure, however, your diastolic is elevated, that's still a problem. If you have a high systolic, relatively high, right, elevated, and your diastolic is below 80, well, guess what? It could still be elevated. It could still be stage 1 hypertension. It just depends. So you got to look at that designator and or, okay? Normal is less than 120, i.e. 119, and below 80 and 79. So if it's 119 over 79, guess what? That is not normal blood pressure anymore. Technically, it's elevated. Crazy, but that's it. Now, the point here is that because we've used the term elevated versus pre-hypertension, clinically, it's not the same significance as when the term pre-hypertension was used. Because as soon as you say hypertension, whoa, it doesn't matter, even if you say it's pre. But now the term elevated puts it back into the hands of the patient. Look, a physician would say, look, your blood pressure is elevated. You better get things taken care of, right? There's no medical intervention, no pharmacological intervention at that point. And that's one of the reasons why they changed it. There's a number of reasons, don't get me wrong, why they changed the designation. And it was a good, in my opinion, it was good. So now you go from blood pressure to the true anthropometric measurements and body composition. And really what we're talking about here is what we normally refer to as body fat measurements. And so you're basically measuring lean, which is everything other than fat, basically subcutaneous body fat. By the way, body fat calipers, for the most part, body fat calipers, the handheld devices, even the gold standard, which is the hydrostatic weighing, cannot differentiate, for instance, between subcutaneous body fat and intra-abdominal. There's a lot of information out there, a lot of research that says that there's a big difference with risk factors based on intra-abdominal, which you can't see. It's stuff inside your intestines and around your intestines, versus just the subcutaneous stuff right outside underneath the skin. So just keep that in mind. Pages 228 and 229 give you a table. Now, don't let all of this written material get you. When you look at the method, it is bioelectrical impedance. That's the method. The next line is basically giving you the type of devices that are used, and then a description. Read through it. Make sure you are very well aware and caught up on the different methods of taking body fat. For the most part, especially in a gym scenario or a small facility, you're going to use either bioelectrical impedance, and there's a whole range of cost, accuracy, and ease of use. There are the handheld ones, not the most accurate, but just keep in mind the description component of it, and you really should know this entire table. Hydrostatic weighing. Yeah, MRIs are used, believe it or not. NIRs, or the near infrared. You're not going to use these things. These are done in clinical settings, skin fold measurements, and total body, but you should know them. DEXA scans are used, right? So there's any number of ways to do this, but you're not going to use probably more than one, which is going to be Caliper Testing or the bioelectrical impedance device. And now you're going to get a explanation of each, basically of each one of those. It's important to keep in mind that the accuracy of your skin fold caliper measurements is going to be based on which standard you're going to use. The ones that are out there are normally 3 sites or 4 sites, and again, you're going to see that through the chapter itself. Don't memorize table 7.4. Obviously, those are the standard values for percent body fat. It simply doesn't make any sense to try and memorize that entire table. Remember, I tell you to memorize tables, but not all of them. Some of them are just informational. You would be accessing this anyway if you were doing skin fold. Now, table 7.5 is important because now the expected change in timeline. So basically, table 5 has just got little 2 elements. What would be the expected change in body fat over 2 to 3 months? This is on average, right? It's going to be a reduction of maybe what they have is 2.7 to 5.9 percentage points. Depends on the starting body fat percentage. So just keep that in mind. And then waist circumference. So anthropometric measurements. Now, this is where it gets a little dicey depending on the client, because again, not every client wants to do a waist circumference measurement, but nevertheless, height, weight, and body mass index, or BMI. Now, remember, BMI is a way of measuring height versus total body weight. It's not a differentiator for body composition. Remember, body composition, body fat, lean body mass. And lean body mass is everything but body fat. It includes muscle, bone, everything else other than body fat. So that's body fat percentage. So body composition, right? Body composition. Then there's body mass index. If you say it slow, you can actually realize the differentiation. Body fat body mass. So BMI basically says you're 6'2", you weigh 250 pounds, you're overweight. If you said that to a 6'2", 250-pound competitive bodybuilder in the Mr. Olympia competition, you would be incorrect. You would be, well, you would be correct that he's overweight, but you would be incorrect in your assessment about that BMI. Okay, for the most part, every competitive bodybuilder I've known, me myself, when I was at those body weights, I've been obese probably most of my adult life for one reason. It's because the muscle mass. So BMI doesn't differentiate. It doesn't differentiate muscle mass from fat mass. So you can have an exceptionally lean, very muscular individual who's technically obese. So, you know, those are the things that we always have to keep in mind, which is one of the reasons why these assessments, sure, if the person is not a weightlifter, not an athlete, then BMI is sure, it's a good idea to just put that down. And the calculation is at the bottom of page 234, table 7.6, classification. Here it is, overweight and obese. So do it for yourself. Go ahead and do your own calculations. By the way, you can do it in kilograms or pounds. Normally now you get the calculation with the correction factor of 703 if you look at that. So table 7.6, you got to memorize that. Okay. You are underweight if your BMI is less than 18.5. You are overweight if your BMI is between 26 to 29. 30 and over is technically obese. Then there is stage 2 or class 2 obese, which is there's obese 30 and above, but 30 to 35 is just regular obesity. 35 and above, actually 40 to 39.9 is class 2. Your risk of developing chronic or having a higher level of dying at an early age, mortality, increases. Those risk factors then increase as you get heavier. And then if you have a BMI over 40, you are class 3 obese. Sometimes at that point, physicians will basically say, look, we gotta get your body weight down. You're just, the risk that you're dealing with right now with this, you know, high level of body weight versus your height is dangerous all on its own. They just want to get your body weight down. This, by the way, as an aside, if you've heard of the ketogenic diet, this is where a diet like the ketogenic diet becomes important. And it's really only at those levels that clinically you can get some really significant clinical changes, right? You can actually see reduction in these risk factors, because on a ketogenic diet, there's going to be a tremendous amount of fat loss. And we don't recommend that at all for people that are not at least in class 2 and class 3 obesity. It becomes one of those, it's a trade-off. Got to get rid of that body weight, got to get rid of that body fat, excessive body fat, to get the body weight down, because that's creating its own risk factor. So now as you move through, you're going to get to, on page 237, again, the mover method, the ABC approach. This is how you would do it. Now, again, read through it. It's a good idea to take your time, look at what the expected response from the trainer is to the client. That's why Ace put these in each of these chapters. So it kind of gives you an idea. Well, how would I use this? Whether or not you're going to see this on the test is probably not, but it's important to read through it to give you an appreciation. One of the things that Ace has tried to do in this particular edition is to help trainers not just pass their exam. We want you to pass the exam, but you need to come back and actually utilize this information in the real world. That's what that is doing for you. Okay, circumference measurements, put the brakes on, read through this, because it's important to measure. When it comes to circumference measurements, one of the reasons why you've got to be technically very proficient at doing this, you got to be accurate, and you've got to do it the same each time. You got to have the exact spot. Each time, the more accurate you are in your measurements, the more accurate, obviously, you're going to be in seeing any changes. And then the idea then is that you would take multiple measurements, and that's why on these bullet points, of course, read through them, make sure you're comfortable with it, and you understand the procedures that you would be going through. Again, like a lot of the stuff we've gone through, a lot of this is just intuitive. However, that intuitive understanding, knowing things, has to be now supported by your ability to actually know the specific. Your general understanding is important, but now, throw on top of that, or throw in between your general understanding, know these specifics. You would do them before exercise. Don't take measurements after they've trained. These assessments should be performed prior to exercise. I would hope that most people know that. The trainer should explain the procedure and ensure that the client is comfortable, right? Well, you know that, but would you know that on a question on a test? And that could be, a little bit challenging. So make sure you're writing these down and you know the sequence, okay? And again, be consistent in both your location. Page 240 gives you a couple of good visuals of exactly where you would do these particular measurements. Waist circumference is a big thing, by the way. Page 241, table 7.7. Yeah, you should memorize this. You should, because these are classic questions on exams. Is, what's a high risk category for a female if her, or a 65-year-old male is got blah 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 waist circumference measurement of this. What risk category is that individual in? It's really important to know those numbers. Waist circumference is also indicative. This is why it's important, believe it or not, clinically, is because it's indicative of these particular health risks. Found at top of page 241. Blood pressure increase, blood cholesterol level increases, right? High density HDL decreases. All of these that's bad, right? You want high HDLs, low LDLs, as low as you can. Triglycerides increase. You don't want high triglycerides. Metabolic syndrome risk increases, and the list goes on. Waist to hip ratio is another clinical indicator that that physicians use, along with BMI. As soon as you add all of these numbers in place, you can see where an individual's risk factors for developing chronic diseases starts to go up. Excess body fat poses significant disease risks. We already know that. We're trying to now assess those and get those numbers more formalized. So as you move on to page 242, table 7.8 gives you a waist to hip circumference ratio norms. Now, I will say this, there's a lot of numbers in here, but what you really want to know is that for men, and again, what I would do is I would take this information and I would put it over and I would summarize it. I would write waist to hip ratios for men, and I would look at the relative ages. Now, you got to remember, men between the ages of 20 and 29, 30 and 39, the numbers are pretty close. What you really want to know is what happens when individuals get older, in their 50s and their 60s, same for women. Those are going to be the numbers. Look at the risk. Normally, questions on exams are going to ask about high risk or very high risk. Doesn't mean that they wouldn't ask on moderate and low, but generally, your standard numbers to memorize for men would be in the 50 to 59, 60 and above. And look at some of those numbers, right? There's not a wide range of numbers, right? It's below 0.83 and below 0.91. So between the ages of 20 and 29, anything lower than 0.83 is good, right? The low risk. But very high is anything greater than 0.94. But look at the very high for men, right at the bottom of the men, the column 1.03. So it's not like you're looking at ranges of 0.2 to 50.8. It's not these massive ranges. The ranges are from the lowest to the highest is normally going to be one point, 1 or 2 points. So I'm trying to help you to memorize the numbers. So when I write down greater than 0.94, that's for 20-year-olds, people in their 20s. And what is it for 60-year-olds? Well, it's not that much different. Anything higher than 1.03. And so I can memorize it a little bit better because I got the ranges kind of down a little bit. And then all you're doing is rewriting, obviously, and do the same for women. Again, the table, probably don't have to memorize the entire table, but just look at the older individuals, higher and very high risk levels. Those are your priority numbers to really get a beat on, okay? And so chapter 7, it gives you this base resting assessment information and anthropometric measurements. Good chapter to review. Remember, memorize the tables, those parts of the tables that we talked about, because now once you start getting into the subsequent chapters, you're going to be doing a whole lot more rewriting and memorization. So that finishes up chapter 7. Remember, read your chapter summary, and then I will see you again on chapter 8.